So my name is Dr. Nancy Albert. I come to you from Cleveland Clinic in Cleveland, Ohio. I'm an Associate Chief Nursing Officer for Research and Innovation, and more important to this discussion, I'm an advanced practice provider in a heart failure clinic for the Kauffman Center for Heart Failure. And then Dr. Khan is going to be giving an overview of the Rise Above Heart Failure pilot program, and then we're going to have a panel discussion, and I'll be introducing our patients and our providers to you. And we want you to be able to join in the discussion, so you'll be able to ask questions as well. The good news is we have a lot of very engaged organizations and a lot of very committed people who are helping us to bring this together. I'm just going to read to you the 5 patient-centered goals, or the unmet needs, and then the goals that came about because of the unmet needs. The first one is patient-centered decision-making. The second unmet need of the 5 that came about when discussions first started was empowering and supporting you, the caregivers, if you're a caregiver in the room. The third unmet need was personalized education and support. The fourth unmet need was symptom recognition and management. And the last unmet need was coordination of care.
So the Rise Above Heart Failure pilot has several goals based on those stakeholder unmet needs. The number one, reducing hospital readmissions among patients with heart failure. And really, this is the primary goal in order to improve quality of life among patients with heart failure, increase patient knowledge of heart failure, including understanding of pathology, symptoms, and treatment, to improve self-management of heart failure through clinical and technology-based approaches, and then to improve patients' sense of empowerment to self-manage heart failure post-discharge, really targeting all of those unmet needs. We know that there are both individual and hospital-based approaches to an intervention such as this. It's not just on one individual or one provider, and that's really where the Rise Above Heart Failure pilot is trying to provide support on all of these levels. So the pilot program itself has 3 hospitals that are participating in the Dallas-Fort Worth area, JPS Health, Medical City, and THR Presby, between July 2019 and April 2020. As we saw in the introductory video, this pilot is providing support to these 3 hospitals through the American Heart Association and Novartis. And the goal is to leverage the Get With the Guidelines sites to identify heart failure patients, educate patients at multiple touch points through the journey, and really make this a dynamic, time-dependent process. It's not just one time. It's not just during the hospitalization, but really the transition following discharge. Drive patient engagement as well as healthcare provider engagement via shared decision-making and self-management education and tools, the heart failure path tools, and provide continuous evaluation of the progress to identify a sustainable model that can then be scaled across the country. The Get With the Guidelines heart failure participation provides national and local recognition for hospital team program achievement, access to the most up-to-date research and scientific publications, professional education and patient education sources, and CMS data submission for 30-day readmission metrics. The Get With the Guideline program has published several papers that have also contributed to our understanding of heart failure admission and the keys that we need to reduce readmissions. So here is an overview schematic of the Rise Above Heart Failure pilot, and I'll walk you through it one by one. We know that there are multiple touch points in the patient's journey, and we want to make sure that we provide support tools not just for the patient or the healthcare provider, but in a group, and make this a part of the patient-centered team decision-making process. In the hospital, heart failure content on the American Heart Association Heart Care channel will provide information about the diagnosis, especially if it is a new diagnosis. At discharge, 60 minutes of targeted heart failure education, so really providing support and time to go over that process. Patient discharge contract, heart failure path enrollment that will provide resources following discharge, magnet board incentive for enrollment, a discharge toolkit, and the heart failure path introductory video on the tablet. And then, as Dr. Albert mentioned, really getting our patients back into the clinic within that 7-day window and providing a digital scale and blood pressure monitoring to patients in need, entry of medications into the heart failure path, medication organizer as an incentive and support for tracking medications, and use of tablet devices for education. And then really highlighting that this will be an ongoing process. It's not just about that discharge to 7-day follow-up, but continues to be an ongoing process to prevent readmissions. While we're focusing a lot of time and attention in that first 30 days, which is the highest window, we know that the risk of readmission persists even after that. Quality of life and knowledge assessments, understanding how living with heart failure is affecting our patients, 12 heart failure education courses assigned by the heart failure team that the patient can continue to do on their own pace. Heart failure path, which allows daily tracking and input. All of our Apple iPhones have kind of daily monitors of our steps and our heart rates, and we're all getting more familiar with this, but being able to leverage this information for the parts of their care journey that we need to know. And additional incentives provided at clinic appointments, such as a fast food advisor and eating healthy poster. When we've done our own kind of stakeholder assessment for what are driving readmissions within our institution, we really have found that there are so many different reasons that are both patient level, provider level, hospital level, and outside of that as well. So some of the things that I'm often thinking about when talking with patients and healthcare leaders are thinking about things like inadequate social structure and social support, system failure, inadequate patient activation or understanding of when symptoms are developing, and biological. Some of our patients are just quite sick, and knowing that some of the readmissions, what needs to be in place prior to discharge to be able to prevent that. Here's the chart that Dr. Albert was speaking about earlier related to the question of where the proportion or percentage of readmissions are occurring. As you can see, this readmission continues from day 0, really, to day 30 from this reference in 2013, and it's not that dissimilar now. That peak that happens at day 3 is not that dissimilar to any other day around that window, but it's quite high and it persists. In fact, 61% of all readmissions happen in the first 2 weeks. One of the things that we've done at Northwestern in order to do our own type of pilot program has been using our electronic health records to identify any individual who's being admitted with heart failure as a diagnosis and provide multidisciplinary support that then allows us to deliver both clinical education as well as leaning on some of our healthcare extenders in social work and pharmacy and transitional care with advanced practice providers. Every patient receives a call at 48 hours, really to target that 3-day mark, not just to assess how they're doing, but how much of their understanding in terms of the education and what they need to be taking for their medications, and ensuring that they have access and we're able to pick up their medications and are able to take them. They get a visit within 7 days with one of our advanced practice providers, within 14 days ideally with their primary care provider, and then within 3 weeks with a cardiologist. Thank you all for your time and attention. I'll turn it back over to Dr. Albert.
Now we're going to start a panel discussion, and I'd like to introduce the panel to you. And the first person I'm going to introduce is Sean Rivers. Sean is a master's prepared advanced diabetes clinical nurse specialist at Case Management Associates Diabetes Wellness Center. Now, her identical twin is sitting right next to her, and you need to know that both of them are heart failure patients. So they were telling us their story at lunch today. They've had heart failure for a while now, and fortunately they're doing very well with their heart failure. Sean contributes time and experiences as a heart failure ambassador for the American Heart Association, and she contributes her time to help educate her community on heart failure issues, as well as telling her own story of survival. And today we learned that she's got a very innovative program about heart failure and diabetes, and I'm hoping she'll be able to share a little bit about that later. Right next to her is her twin, and her twin is Kimberly Ketter, and Kimberly is an adult geriatric nurse practitioner and also a certified diabetes educator at the Case Management Solutions, LLC. And again, she also has heart failure, was diagnosed with heart failure after her sister. They both live in Petersburg, Virginia, and her focus is also on managing and educating adults with type 2 diabetes and other cardiometabolic issues, including obesity and hypertension. The person to, I guess, coming down toward me, they're right, it would be Amy Rodriguez And Amy is a heart failure ambassador. So we learned a little bit about her story today. She's a mother of 3 from Woodbridge, Virginia. She survived cancer and then was diagnosed with cardiomyopathy and heart failure. Amy was also determined not to let her heart failure diagnosis stop her from pursuing her passion, motorcycle riding. So last spring, she organized a charity to ride in her hometown to Woodbridge, Virginia, to raise awareness about heart failure in conjunction with the American Heart Association. So she's bringing good things to life. Next to her is Allison Roberts. Allison is a nurse practitioner, and she's a practicing practitioner, and she helps support one of the 3 pilot centers that you heard about earlier at Medical City Plano. And then next to her is Greg Duck. He is a physician's assistant, and also he supports another one of the 3 pilot centers. He's at JPS Health Network. And then you've already met Dr. Khan. So I think one of the questions that we may all want to know are what components of the program have been the most difficult to implement?
I can kind of speak to that a little bit. So I think in the impoverished populations, typically where I work in Tarrant County, there's not a lot of access to buying a data plan, and so things like having a tablet aren't really very practical. And that's something that the organization is working on and finding alternatives to provide those. They've kind of taken measures to create packets where people can track their daily weights instead of entering them into a tablet. And so that's been a good movement so far.
So, Amy, you're one of our patients. Why don't you tell us from your perspective, so that we've heard the provider perspective, from your perspective, what do you think is the most important thing that has helped you to manage your journey with heart failure?
For me, I believe the information. One of the things that when I initially was diagnosed, I was actually just kind of handed a red folder and was explained I have heart failure. For me, as a patient, that's information overload. You have 1,000 things going through your mind, so me reading what was in that folder, I'll be honest, was not at the top of my list at that moment. For all the information that's out there, one of the things that I like is this, because it allows me to check and see what are some of the things that I should be looking for. And one of the things that I wish I would have knew about this sooner, prior to being diagnosed, because of the fact that I would have knew what to look for, because for me, I didn't feel sick. The only thing I was just really tired.
Sean or Kim, if you guys can maybe help us understand, are there things that in your interactions with your providers that they've done well, or things that you wish that they'd done better during your journey?
For me, it's a little difficult because I'm provider and patient, and nurses historically are horrible patients.
Bad patients.
We just are. We can heal the entire world, but when we have to look in that mirror, we're like, nah, I got this, and we do everything but what they're asking us to do.
Yeah.
So for me, though, even at diagnosis, when I was told that I had cardiomyopathy, and as a provider, I still wasn't trying to hear that, and what I wish they would have done was to not speak to me as though I was a provider. They gave me all the verbiage. In that moment, I was a patient. You know what I mean? So after he told me I had cardiomyopathy, I heard nothing else he had to say after that. It scared me to death. I cried like a baby. I wasn't a nurse practitioner in that moment. I was a patient. So that's just one of the things, if I had to mention that to other providers, is that no matter what your patient is, just give it to them straight, but with compassion and empathy, of course. But don't just assume that we know things, because even though we do, we're not hearing it. It just didn't hear it at diagnosis. So still just giving it to me straight was really helpful.
Yeah, I think that's probably one of the hardest parts of my day, is telling somebody that they have heart failure. And I think maybe, Sean, if you can comment, what are the things that would be helpful to hear as you're hearing that message?
Well, my sister, she was diagnosed first. So it's almost like I sort of knew it was coming, but I didn't want to know it was coming, because I was diagnosed maybe 3 weeks after she was. But even in that moment, like she said, you hear it, but you didn't hear it. So it was almost sort of the same type of thing. And you hear it all, but in that moment, my first thought was, I don't want to die. You you work with congestive heart failure patients and you see that image in your head, and I didn't meet any of that criteria at all. We didn't have high blood pressure. We didn't have diabetes. We weren't overweight. We were pretty active, but we didn't meet that textbook look of heart failure. So in that moment, they told us, Miss Rivers, you have heart failure. And it was sort of just that. They said, we're going to start you on meds and come back and see me in 3 months, and kind of left. And I'm sitting there like, what just happened to my life? So just in that moment, just take a few more minutes just to have that little extra when you sort of drop that bomb.
When you're working with patients, what is it they tell you what they want more of? What most often comes to mind that they need that, we talked about the 5 unmet needs that Rise Above Heart Failure is targeting, but in real life, what do patients want more of?
I think on a human level, we just want to trust somebody.
Yeah.
And that's something that I feel like this program has really brought out, front and center. If I don't have a relationship with a patient and they don't trust me, I'm just some guy sitting in a room telling them a bunch of things that they probably may or may not believe. I think it's been helpful, being able to capture somebody in the hospital and meet them for the first time, tell them these things that they need to hear, but let them know that there's hope and that this is something you can live with. And then you can give them tools to help them with this thing that is now a part of who they are.
What I emphasize to folk that I talk about, there's a lot to be said about cultural sensitivity. A lot of the folk just want you to know that you care and you hear them from a place that you get it. So it's not, someone mentioned that earlier, it's not just being sympathetic, it's being empathetic.
So when we talk about heart failure, we talk a lot about having patients be in control of their health as one way for them to feel better, have better quality of life. So speak to me a little bit, the providers can talk a little bit about how the pilot program has helped to increase patient control, and some of the other providers may want to talk about what they do in their own practices to help increase control.
Well, I think from initially when you're diagnosed with heart failure, your life changes. The way you eat, the things you do in your daily activities change. And to expect patients to go from A to Z, in that 3, 5, 7 days they're in the hospital is really hard. So giving them somewhat control with the HF Path app gives them access to understand those things, to process those things, to, change their dietary habits, slowly understanding how they need to be more active, looking into their medications, being compliant with their medications. It gives them a tool to track their weight daily. All those things, they're relatively simple things, but if you put all those things together, they're extremely important, and that's what we really need to look at, I think.
I think probably that was probably one of the hardest things for me, and and I'm a nurse and I know better, but the diet piece was really hard. If you're a nurse or you work in the healthcare field, you eat on the go all the time. And I was sharing with you, I was the queen of the Slim Jim. So, and it had to be the one with the cheese on the side, but diagnosed with heart failure, the salt is off the chart. So there are a lot of things that you had to change in your diet. So I share that story with my patients, that you're not alone in that healthcare lifestyle change. It's difficult, but it can be done.
One of the other things that we share, and we tell our patients all the time, is that we tell our patients that they are the CEO of their healthcare. They are in the center of it all.
That's wonderful. I think one of the things I've heard a lot about is how this term heart failure, you guys are mentioning cardiomyopathy and heart failure, but just that term itself and the connotation that it carries. So I think one of the things from the question that I have is how can we better provide or transition that as well? And one way I think the pilot is doing it is making it rising above heart failure. So overcoming this and providing resources for overcoming it. What are other things that you guys think may be helpful in how it's explained or this terminology that carries a lot of weight?
It's not a death sentence, and folk will look at Sean and I all the time, and we go. Now, there's too much work to do to lay down and die. I'll have plenty of time to do that later. But they look at us and say, no, you can't have heart failure. And we say, exactly. I don't want to look like I have heart failure. I don't want to look like that typical person that's, sleeping and, not moving around. I still want to live a very active life. And it can be done if you do A, B, C, and D and kind of manage it with the things and the apps and things that are possible. So we just want to stand and be like the light in that dark place. The word heart failure is scary. Even as a nurse, when I heard it, I was like, you got to be kidding me, heart failure. Because a lot of people, if you ask them what heart failure means, they say, is my heart going to stop? And they have this misconception about what heart failure actually is. So the way we explain it is, well, it's not that your heart stops. It just means that you have a weakened heart. It's not pumping the blood like it's supposed to. It's kind of a floppy heart, and we equate it to a rubber band. I tell them, if you imagine one of those little small black rubber bands, and you pull it and you let it go, it pops like that. That's a good heart. But now if you get the big floppy one that you get like at the post office or something, you got to pull it way back here. And if you let it go, you're still not going to get that pop. They get that. They need something visual a lot of times to get it. So they say, oh, okay, so I need to be the black rubber band. I say, yes. So that means you take your medicine the way you're supposed to so we can get it that way. So it's just things like that I think are really helpful. Just put folk in charge. And we always say, we have heart failure, but it doesn't have us.
All right, so now I have a question for Dr. Kahn and for Greg and for Allison, and that is that when we put transition programs in place in Cleveland, one of the big lessons that we learned was that you really have to have strong leadership. The leader doesn't have to be the director of the program or a physician or an administrator, but it's got to be a strong leader who is able to really make sure things happen and who has the authority to make sure things happen. So I'm curious, you guys are part of the pilot program. Do you have strong leadership, or do you feel like you're kind of riding the ride and it may fall apart at any time if you go on vacation even, because there's no one there to really manage the shop? So it's just a Cleveland thing, or if you agree that really the leadership is really important?
I think that's a really good question, because I think it's a problem everywhere. I think in general, as healthcare providers, physicians, PAs, nurse practitioners, nurses, everybody, we could all do a good job about talking to each other better. Mm-hmm. For example, if an ER sees a heart failure patient and they don't know they have heart failure and their blood pressure's low and maybe they think it's sepsis and they haven't asked them about heart failure, well, that's a problem. They might get bolused with a bunch of fluids and throw them into fulminant cardiogenic shock. And so I think, getting together with a nuclear team of your clinic, whether that's your nurses, your advanced, practice providers, your physicians, and having the conversation with everybody else in the hospital about, this is how we typically manage heart failure. This is how we do it. And then when you have those conversations enough, you start to get some traction and things start to change. We've noticed that, they start to, treat volume overload more differently in the ER setting now. And that's a good thing.
What are some of the challenges with scaling one program like this and making it a little bit of a one-size-fits-all? And it'll come back to some of that sociodemographic as well. In different counties where there are different resources or different neighborhoods, how do we also then more specialize it based on the area?
So for us, we developed I call it a virtual huddle. I don't know if the rest of my team would call it a virtual huddle, but we have 1,400 beds on the main campus, and heart failure patients could be anywhere. And then we have 11 hospitals in Northeast Ohio. So our heart failure patients are spread out, and there are some communities in Cleveland that are extremely poor and others that are more well-to-do. And so what we've done is we've developed this online or virtual huddle that's in our Epic, and a patient cannot be discharged from the hospital until everybody who's supposed to sign off in the virtual huddle has done so. Does a patient require a care coordinator or a social worker based on their risk for rehospitalization? If yes, they have to show what they did and they have to sign it. It's not just a checkbox that's anonymous, so we know exactly who did the work. Are the patients on the right drugs at the right doses? If they're not, why not? not. And so we have to list the contraindications so everybody knows why the patient's not on a drug. Is the patient getting cardiac rehab if that's the next step for them? Are they getting their 7-day follow-up appointment? We actually make a 7-day and a 30-day follow-up appointment before they're discharged from the hospital. And then we try to have some education around it as well. Many patients go home and they're feeling good. We just diuresed 27 pounds off of them or whatever's going on. And so they're thinking, why should I go back in for a 7-day visit? It's going to cost me money. And so we try to explain to them, no matter what their socioeconomic status is, this is our way to tweak your condition, to up-titrate drugs if we need to change a medication if we overdid it at discharge. So we really try to spend time educating patients at their level in an individualized way. We try really hard to give everybody a phone call within 48 hours. So again, as long as they have a telephone, we could talk to them. And we have learned that many of our disadvantaged patients do have cell phones. They may not have other things, but they do have cell phones. And so it's easy enough for us to get in contact with them. Now, sometimes the cell phone number dies and changes, and we have to find the right cell phone. But they do have cell phones, and so we try to talk to them and make sure, did you get your discharge medications? We were learning that people would wait a week just to go to the pharmacy and get their prescriptions filled because they felt like they didn't need to rush. They're feeling better. And so, again, it's learning those little lessons and finding out where the gaps are and then trying to fill the gaps no matter what the context is, that everybody can be a win-win from that scenario. So the next question is, can you talk about working with providers beyond the walls of the hospital or clinic? How do you really address transitions of care to sustain heart failure management or beyond that hospital setting, whether it's assisted living or skilled nursing facilities or other avenues of care? Because not everybody goes home and they don't just come back in very simply. I don't know if any of our providers can help answer those questions.
Yeah. So one thing that we're trying to do at our site is to incorporate like a mobile heart failure bus or a truck. And what we do is we are going to identify high-risk patients who are going to be readmitted with heart failure and take it to them where they live. And it's not like a new idea. There were several posters last night with the Get to the Guidelines meeting last night where people are doing this already. Fire departments, people that live in Wisconsin are doing this, and they're getting really great results. And their point is that, you know, when you're in the hospital, when you're being told all these different things, like you have heart failure, and like you said earlier, that was the last thing I heard, and then I kind of checked out because you're in this setting where you're not in your home, you're not familiar with anything, and then you get all this information. And so when you go home, if someone can come to you and make sure you have what you need, medications, a pill box, tips on how to eat, here's your medicine that you take to not get too overloaded. I mean, it makes a huge difference, and they found that this dramatically reduces rehospitalizations as well.
All right, I had one more question that came through, and it's another simple one, is the virtual huddle through the electronic health record. And initially it was on paper for us, and we developed it on paper. We ran with it for a 3-month period, a trial period on just our heart failure floors. We had 3 heart failure floors on the main campus, and it was so successful that we did put it in the EHR, and now it is electronic, so anybody could see it anywhere. And to give you an idea, our rehospitalization rate dropped from about, this is in the areas we're using it on main campus, from about 20.9% down to 13%, which is huge considering that we get the sickest of the sick patients. There's a lot of complexities, not to mention the socioeconomic issues, but just issues of having, end of life, a lot of medical conditions on top of the heart failure, patients that are pre-VAD that may end up coming back in, so that includes all heart failure hospitalizations. All right, well, we've come to the end of our hour here, so I first and foremost want to thank our panel for being so open and willing to share your stories and a little bit about what works for you and how you make heart failure work from a day-to-day scenario. So thank you, Allison, Greg, Amy, Sean, and Kimberly. And also Dr. Khan for being a co-facilitator with me today. Thank you again.
think the Rise Above Heart Failure pilot is going to provide us very important information. And as we heard today from some of the providers that are participating, is that there are certain aspects that are very helpful, the education material, the resources, and there are certain aspects that are difficult. Having a tablet or having access to a tablet is not always possible for all patients. So being able to understand and tease out some of these nuances during the pilot stage and be able to understand what we need to then scale this nationwide. We talked today about how different healthcare systems are trying to introduce care coordination in different ways. What are the resources needed for each community, which may be different, and really being able to understand what are the drivers for readmission and address those.
We need to make sure that the leader who is supposedly in charge of whatever programs are in place is really leading. They're not leaving it to somebody else to lead. Yes, other people can take the program and move it forward, but are we seeing the results every month? Do we get quality improvement data? Do we discuss that quality improvement data with our teams? And do we recognize that the team is only as good as the lowest performer? It's like a lawyer's office. You're only as good as the partner who's performing the least. And so we need to look at it in a way that helps us all rise up and do better. The second factor is quality improvement initiatives. Hospitals that have formal quality improvement initiatives with a leader, but more importantly, everybody on the team knows what it is they ought to be doing, where their goals are, and how they're going to get to the goals. Those programs will do better than hospitals that really don't pay attention to quality improvement at all. And then the third thing I would say, it's a pretty global one, but it encompasses a lot of arenas, and that is communication and collaboration. It takes a village to manage heart failure, and so who are the teams that you've put in place? Do those teams communicate with each other, and how do they communicate with each other? I mentioned that we have a virtual huddle at the Cleveland Clinic. That's one way of communication, but in a small facility, it may be in-person communication every day at 4 p.m. and going over all of the cases, or it may be at the bedside with physicians, patients, so the patient and family are right there hearing the message as the team is discussing. And that also lends itself to shared decision-making and getting the patient involved in their care. So when it comes to heart failure, oftentimes patients know what to do in terms of taking care of themselves. They simply do not know how to do it. We, as providers, need to teach them how to do it so that they can do a better job of activity, diet, fluid management, all the different pieces we want them to take care of on their own.